Hey, this is Dr. Samuel Ndeshimie, a practicing dental surgeon at Rwanda Military Hospital. Today I'm going to present about emergency management of oral and maxillofacial trauma, including prophylactic antibiotherapy. This is a very good topic for practicing dental surgeons, dental and medical students, as well as residents who are rotating in emergency and also in surgical departments. As outlines, we are going to see about the introduction of oral and maxillofacial trauma, etiology of oral and maxillofacial trauma, assessment of patients with oral and maxillofacial trauma, soft tissue trauma, mandible, mid-face and dental trauma and their emergency management. Then we are going to take a look on their complications. Thereafter, we'll see about the prophylactic antibiotherapy. So this presentation has three parts. Mainly, the first part is about the emergent management of trauma. Then the second is the oral and maxillofacial trauma types. And then the third, it's about the antibiotherapy. So as an introduction, what's tissue trauma? We do say that there is a tissue trauma when there is a damage into the tissue caused by either physical, thermal, or chemical agents. So the oral and maxillofacial trauma becomes an emergency if there is an airway compromise, if there is a brain injury, C-spine injury, or aversion of tissue. All of this make our patients vulnerable to death. So oral and maxillofacial trauma is a region that is crucial because it is the entry of airway, masticatory, digestive, and also it helps in speech and aesthetics. The facial injuries deserve special attention because of their complications and aesthetic significance. So facial traumas are life-threatening because most of the time they are associated with airway compromission and also they are high bleeding and they are the wounds in the face once they are communicating with the oral or the respiratory tracts, they are infected, and as you know, the infected wounds, they are never clean. The oral and the wounds that are communicating with digestive or respiratory tracts are contaminated, clean contaminated wounds. So once someone is injured and there is communication between respiratory tracts and digestive tracts with the wound, that wound is contaminated. So serious attention has to be taken to clear the infection and to make sure that the tissue are not going to progress with necrosis. So injury caused on the face are caused by motor vehicle accidents, fire, fights, and most of the time here in our region, domestic violence is also prevalent. Facial trauma is among the common causes of maxillofacial emergency. This is one of the causes that cause oral and maxillofacial surgeons or residents to go on calls frequently. It may be associated with other threatening injury like C-spine, brain injuries, and it can be associated with extremity injuries in particular. So about the etiology, most of the causes, they are from accidents, falls, sports, fights, and domestic violence. Here, this is the study done here in Kigali city at one of the teaching hospital we have called Sashika, where motor vehicle accidents were amongst the more prevalent causes of OMFS trauma, followed by motor car collision and fire accidents, then bicycle, assaults, domestic violence, sports, and others. So on classification of oral and maxillofacial injuries, we have soft tissue trauma and hard tissue traumas. So on soft tissue we have abrasions, contusions, ecchymosis, lacerations, and avulsion. Then on hard tissue we have the fractures. So the fractures are classified into the thirds of the face: upper third, mid third, and lower third, which implies upper face third is about the above the orbits, mean the supraorbital region, mid face maxilla and zygoma, then lower face mandible. We do have also displacements of the bones, especially the bones which are more prevalent to displacement are zygoma and the nasal bone. When they are fractured, they are usually displaced. Dislocations, so TMJ, temporomandibular joint, usually dislocate during trauma. And we have also teeth and dental alveolar. Emergency management of oral and maxillofacial trauma is like any trauma management. So we just have to do advanced trauma life support, which is having two components. The first is primary survey, then the second is the secondary survey. So we do triage in casualty when there is a mass casualty of trauma, where we select the patients and we see the ones who needs the special attention and emergent treatment, and then we do resuscitation accordingly. We do adjustment of primary survey. So this is summarized as A B C D E. And after this, I know most of you know this abbreviation, where A stands for airway, B stands for breathing, C for circulation, and E for exposure. So secondary survey is composed of like AMPO. It's the abbreviation given for it, where A stands for allergy, M for medication, then P for past medical history, L for last meal, and E for exposure. So about the emergency management, we do triage for as I mentioned, for mass casualty, where we look for more critical patients, and then they have to be saved first. And also this is based on ABC priorities. When we say ABC, means airway, breathing, and circulation. So someone who is having airway obstruction, or who is not breathing well, or there is compromission in circulation, these people need special attention at emergency. So on primary survey, we do airway and C-spine protection. We have to look in the oral cavity, and we see if the patient is having any clot there, or anything that can obstruct the airway. Then we see how we can protect the C-spine. On at this stage, if someone is not breathing, or the airway is having foreign bodies, have to be removed and see if the patient can breathe. If not, the intubation is advisable. The second thing we look on is about breathing and ventilation. We see if the patient is chest is expanding, and if you have a stethoscope, you can feel the breathing sounds. So if not, then we have to anticipate on his breathing by opening the airway. There are two maneuvers that we do to assist in opening the airway, so the patient can breathe. This is jaw thrust and chin lift. So on C, we see for any hemorrhage, and if it's there, we control the hemorrhage, or we apply compress. If there is like low blood pressure. If we see on the vital signs, we have to anticipate. So low blood pressure, it means someone is losing much blood. We have to see the cause, and then we do resuscitation. We give resuscitation fluids, either crystalloids for resuscitation of cardiac output. On D, we see disability. This is where we assess the GCS, Glasgow scale of the patient. If he is able to open the eyes spontaneously, or she can move her or his arms, or he can respond to the command. We see how is he oriented, and based on this is where we are going to classify if he's having severe, moderate, or mild head injury according to the GCS score is going to have. On E, we do exposure to see what really other injury that can be associated with oral and maxillofacial trauma. Maybe the patient might have a chest trauma, or might have open fractures of elsewhere on the body. So we have to look on that, so that on our first or our primary survey, we save the patient from dying at the scene. This is what we call the golden hour. On the secondary survey, it's summarized as ample, as I mentioned, where A stands for allergy. We have to see if the patient is having any allergy. So the first, the primary survey is done, then the patient is stabilized. So if he's recovering, you have to ask him or her about the allergy. If she has or he has an allergy, you have to prevent this as much as you can. The second, you have to know about the medications that the patient is taking, because this plays a lot. It's like when someone is taking like anticoagulants and you are struggling with bleeding while the patient has taken anticoagulants, so you know that the success rate will be low. So you can negotiate, or you can adjust if you can reverse the effect of anticoagulants, or you can anticipate in either or another way. So you have to know about the past illness of the patients, including pregnancy. So this plays a crucial role, because like most of the patients might be received at emergency, while they have other significant disease that can be fatal to that time. And also we have to know about the last meal, because this is very crucial for anesthesia. And also we need to know about the status of well-being of the patient. Maybe he's having a hypoglycemia, so we need to know about it. And also we need to know if the patient is alcoholic, if he has taken an alcohol, so that we can adjust our treatment accordingly. Then we see on the secondary survey, we have to expose the patient as a whole. We look on the back and the front, so that we can see any other injury if it's there. Then we ask about the events, what happened, and how does the injury happen. That can also give us a clue about the treatment. So on airway, we call the patient. If he is not responding, then we consider the airway to be compromised. So you call his name or her name, and if he's not responding to you, you know that there is something that hinders him or her to respond. So inspect for any foreign body, for facial or any mandible or laryngeal or tracheal fracture. So you palpate to see if there is something that has broken the airway. You have to have a good suction, so that it is going to help you to suck all the clots and oral secretions. Jaw thrusts and chin lift maneuvers are used to open the airway at emergency. Then if this is advised for an unconscious patients who are not having gag reflex. So if they are not having ways to control the airway, we have to press an oral-tracheal intubation. Then we prevent excessive movement of C-spine, as we do not know the status of C-spine. The patient might have it, might have C-spine injury. So after the airway is secured, we press a C-collar. Then on B, breathing and ventilation, we ensure the patient chest is expanding properly, and we use a pulse oximeter to see hemoglobin saturation. Then we look for signs of tension pneumothorax. So this time it's where you do percussion and see you will feel the chest is more resonant. Then there is what we call massive hemothorax or open pneumothorax, and also there is a trachea or laryngeal injury. So we say patient is having massive hemothorax when there is bleeding into the pleural cavity more than 1.5 liter. So this time when we do the compensation with the needle, if the patient is having an pneumothorax, and if there is an hemothorax, we call for surgeons, general surgeons, to press uh, a chest drain for a removal of the blood. So tension pneumothorax affect both circulation and respiration. So this is an emergency because you can have patients with who is not breathing, and also the heart is not beating because of this tension pneumothorax. So needle decompression is advised. Here, this is the good images that shows that that shows the chin, the chin rift, the jaw thrust and the chin rift. And on this down, yes, you can see on this down left image that the patient was having obstructed airway, and by doing the chin rift, the airway is open. On the left one, these are the landmarks for needle decompression when the patient is having uh, tension pneumothorax. So on the left side there is, so on circulation we assess cardiac output and breathing. We quick identify and control the hemorrhage when it's there. If there is a tension pneumothorax is excluded, so hypotension is the cause of shock until proven otherwise. So that's why we have to assess cardiac output and give fluids and blood if it's indicated. Then there are three elements to assess when we are assessing the cardiac output. We have to assess the level of consciousness. So the patient, if she or he is stable or he's having altered mental status, this may be due to the diminished perfusion to the blood. Then the skin perfusion, this is seen by just examining the patient. You will see the face is pale and the extremity are like gray, so they are pale. And when we do capillary refill, it is delayed. Also, the patient will have cold extremities, so we also feel the pulse on radio artery. But also, if the radio are absent, we have to look for the central pulse either at the carotid or at the femoral. If the femoral artery pulse is not present bilaterally, we have to anticipate immediately. So this patient has lost much blood, and then the blood is the minimum amount of blood left is perfused to the vital organs like brain and the liver. So we have to anticipate giving fluids and blood if indicated. So external breathing has to be controlled by direct pressure, but if it's on the extremity, it's on the leg or it's on the arm, so the pressure is not controlling the breathing, a tourniquet can be applied, but this is associated with causing gangrene. So there are major areas of internal bleeding, which are in chest, in pleural cavity, in abdomen, like in retroperitoneum, in pelvis, and in long bones like femur. They are heavily bleeding. So at this time we use imagings that will help. There are what we call city imagings for trauma patients, where we do head, chest, abdomen x-rays, and also we do fast ultrasound or focused assessment with sonography for trauma. We anticipate by replacing the lost blood by giving crystalloid fluids, or if indicated, like when the patient is having low hemoglobin, we give packets of red. At emergence also, we have to look on disability, where we see the GCS of the patient as I mentioned. We look on the papillary size and the reaction. We look on the papillary size, where if they are reacting equally on the right. We have to determine the spinal cord injury level by assessing the dermatomes, if it's there or not. We also have to keep in mind that decrease the consciousness of the patient may indicate brain hypoxia or hypoperfusion, hypoglycemia, or direct cerebral injury. So when we see a drowsy or a disoriented patient, keep in mind that he or she might have a brain hypoxia, or she might have a reduced cardiac output, so that the brain is not well perfused, or she or he might have hypoglycemia, or there is direct trauma to the brain. So adequate oxygenation and perfusion is advised. So that's why for these people we don't delay assessing many things. We do have to give oxygen, and also we have to give them fluids, so that the brain is saved from the hypoperfusion and hypoxia. So we do exposure to remove the clothes, and you see the patients if he is having any other injury apart from oral and maxillofacial region. So also after assessment, uh, we have to cover the patient to prevent uh, hypothermia, because this is also an issue at emergency. People might die due to hypothermia. Also, the IV fluids that we are providing during resuscitation, we have to make sure that they are warmed at room temperature. So on secondary survey, we do head to toe examination. As I mentioned, we look for allergy, if there is any allergy, medications that the patient is taking, if there is any past illness, like and also pregnancy. We see the last meal, as I mentioned, and if there is an alcohol intake, because patient may be having decreased level of consciousness while he is having alcoholic altered mental status. We do also exposure and ask about the event, what happened, what caused the trauma. So this is the end of the first part of the presentation. I welcome you on the second part of the presentation, where we are going to see the assessment and also the types of oral and maxillofacial traumas. Thank you.